Good evening, everybody. Thank you so much for joining me tonight for YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and I'm pleased to have you join me tonight as we celebrate Men's Health Month. Now, Men's Health Month has been around since 1992, and actually, I didn't know that until a few months ago. And it came about by interested groups, focus groups, and wishing to increase a men's awareness so that we have earlier detection and treatment of various disease states. And we're growing at this point. But I want to just start off, and here's the important thing actually too, is that I often talk about lifespan versus health span versus lifespan. But if you look at just health span in itself, or lifespan, I'm sorry, so women live on the average 6-7 years longer than men. Why is that so? Is it because we make poor choices in the kitchen, smoke more, drink more? Men have also, we have less hobbies, less interests. And what exactly is it all about? And we're not quite sure. A lot of it is lifestyle, but one of my aims is in interest in men's health is to help narrow that gap so that we don't have 6 or 7 years between a difference of a lifespan of a man versus a woman. A few facts. 450,000 men die every year of heart disease. So when you compare that to women, about 300,000 women die every year of heart disease. More than 700,000 men are diagnosed every year with some type of cancer, and over 300,000 will actually die from that disease. So that's almost half. And 230,000 men are diagnosed every year with prostate cancer. It's the most common cancer in men, second only to lung cancer. Actually, 1 out of 9 men actually come down with prostate cancer. When you compare that to women, about 1 out of 7 contract breast cancer in their lifetime. Other facts. What about mental health? Well, men that are physically inactive actually are 60% more likely to suffer depression in their lifetime. So physical activity is extremely important in men as it is in women. And men who sleep 7 or 8 hours a night versus 5 or 6 hours a night are much less likely to die of a fatal heart attack. So sleep is very important. Men are also, as you probably know, are less likely to seek health care. And I used to joke about this when I started my practice many years ago, that why is it that men don't call for help unless they're in the ambulance with chest pain? And it's really true. It's gotten better over the years, but men generally don't do routine checks, health checks, as opposed to women. So it's a difference in itself. And mental health has been terribly stigmatized in the male population, and yet depression is seen in at least 30% of men in their lifetime. So let's just start off with prostate health. And prostate cancer, as I said, is the second most common cancer, and it increases with age. And we see it most prominently in those over the age of 65. So can you prevent it? Well, yeah, certainly lifestyle is really important here. So first of all, think red. So things like tomatoes, watermelon, red peppers. It's because there is a phytochemical called lycopene that you've probably heard of. And by the way, if you like tomatoes, make sure they're cooked, because actually you get the higher concentration of lycopene that way. Also legumes, fruits and veggies, less alcohol. Very interesting. Caffeine has been shown to be useful in preventing prostate cancer. We're talking like 6 or 7 cups a day. I don't know who could drink that much coffee. And would I recommend it in my cardiac population? Probably not. But caffeine has been shown to be useful here. Also exercise and fish oil. So that's the preventative measures. But the screening is really what we're trying to get across. So it used to be that age 50, it still is, the American Cancer Society recommends that age 50 is when we start getting screened, which is called a PSA, which is a prostate screening antigen, which is the test we use to screen for prostate cancer. So usually age 50 is what's generally recommended. I generally go earlier than that. And it's age 45 if there is a high risk of developing prostate cancer, and that's if there is a first-degree relative that has had prostate cancer. And even age 40 for higher risk people, African-American population, and also those that have more than one first-degree relative with prostate cancer. So it's very important. How often should we do screening? I do it yearly. That's probably overkill, but they say at least every 2 years, 2.5 years. Now, what about colon cancer? that really came into the light last year, August of 2020, when Chadwick Boseman, the actor, died very young, age 37, I believe, of colon cancer. Now, so it really made people think, well, the prevalence of this disease, and it's a very common disease. And I tell people screening is so important because screening in itself doesn't really prevent colon cancer, but what it does do is prevent death from colon cancer, because most of colon cancer starts off as non-cancerous polyps that develop into cancer, and then it can spread from that point on. So the disease is so preventable if we get it at an early age. So when do we do the screening? It used to be age 50. Okay, that would be your time for your first colonoscopy. Now we're thinking more like, well, probably age 45, especially if you're African American, or if you have a family history, or if you have inflammatory bowel disease, such as Crohn's or ulcerative colitis, and probably even earlier, like age 40, in certain high-risk groups of any genetic predisposition. And prevention, same thing as we talked about prostate: veggies, no alcohol, exercise. In fact, prevention of cancer, whether it's prostate cancer or colon cancer, is pretty much the same thing as we prevent heart disease. It's basically healthy eating and healthy lifestyle. So now I want to switch gears and talk about testosterone, because that is the male hormone. Testosterone replacement therapy is what we do, what I do, and the longevity side of my practice. And first of all, I want you to know, how do we define it? Well, there are lab values that we use. And so if you look at most labs across the country, it's between like 250 versus like 1,000. So why would you want to be 250 if you could be 1,000? And that's because it's age related. So if you, 1,000 is what we generally see in in a 25-year-old male. So whether you're a male or a female, we have our top level of hormones at age 25. And from that point on, we start aging from an endocrinologic standpoint. With women, it's very precipitous, as we talked about last month with women's health. And men, it's very insidious. It's years in the making before men really, really feel it. And before I go on, I just want to say, do I treat everybody with low levels? The answer is absolutely not. First of all, every patient is individual. There's some patients have low levels, less than 200. I saw one about a week or two ago who is completely asymptomatic. He has good sex drive. He works out in the gym. He doesn't have any mental fog, any brain fog. So, treat these people unless you have a medical reason to treat, or unless you're symptomatic. Now, what are the symptoms? You all heard about this. It's, less strength, less muscle mass. Basically, you're in the gym and you're getting less bang for the buck. That's what I call it. You're working out hard. You're not getting the same results you once got. Reduced erectile function. We lost of that morning woody that we call it. Also, loss in libido is very common. Fatigue. Men start noticing fatigue, loss of energy, depression. The most common cause of depression in middle-aged men is low testosterone. I don't know why people don't consider that. They rather give you these SSRIs and medications for depression, when if it's really hormonally based, wouldn't it be like a lot better to just try that first? So that's something else to consider. Also, less motivation and drive. I have men that say, I don't have the same, but I go to the gym. I don't really want to go. I don't have the initiative to do my lawn anymore. It's the I don't care attitude. And basically it's the grumpy old man syndrome. And so how about administering testosterone? So once we made the diagnosis, and once we've seen that the patient is symptomatic, then we go ahead and say, okay, let's administer testosterone. And so how do we do it? And actually, there's two main ways: by injections, or we can use topicals or gels. Oral is no longer being used because oral testosterone goes to the liver first, and it actually has to be metabolized to something that the body can assimilate. And in doing that, the liver takes a beating, and we don't want to. We need that liver. Liver's got like 450 functions. So basically, it's gels and also injections. They both work. Testosterone is testosterone, except about 12% of men or more, I have found, just do not absorb the topicals. I can't tell you why. No one really knows why. It's not because of body hair. Certain men just don't absorb it. And that happens, so we switch to injections. Now, the gels and topicals have to be administered daily, on a daily basis, whereas injections is once a week. but they both work. And as far as follow-up is concerned, essential. Okay, it's essential to have follow-up. Now, how I generally do it, how I've done it for 22 years, is that I usually, if we start them on testosterone, I'll see them within 2 months with labs, and then I'll see them quarterly for the first year, and usually twice a year thereafter, as long as they're on the medication, because hormones affect multiple organ systems in your body. And as a physician, I want to know how you're doing. I want to see you. I do a lot of remote consults and so forth. But if you're on hormonal therapy, I do want to see you once a year physically in my office, because there's nothing like seeing one physical and doing a physical exam. Pitfalls. I don't think there are any real pitfalls in using hormonal therapy, testosterone replacement therapy, if you're going to a physician who is well-versed in the testosterone and its administration. So now besides being a cardiologist, I'm board certified in anti-aging medicine. So I have extensive education in this, training in it. So you just go to someone who's got similar training or certain endocrinologists. Now, endocrinologists tend to be conservative, and they specialize in diabetes and thyroid disease, et cetera. They may or may not be really up to snuff when it comes to testosterone. A lot of them that I have met are like, they're really kind of anti-testosterone, as is a lot of the medical profession. So you want to make sure you're followed by someone who's qualified. I don't think, we'll talk more about this in the question and answers. Hopefully some of you ask this. What about prostate cancer? What about heart disease? And a lot of these are old theories based on old science, which were never, and deeply flawed studies. But I'm here to tell you that taking testosterone should not lead to prostate cancer or lead to heart disease. It would be an oxymoron for me as a board certified cardiologist to give you testosterone if it could potentially hurt your heart, right? It doesn't make any sense. But a lot of these reports are really not valid scientifically, and we can talk more about that in the question and answers. A couple of things I want to talk about before we go to the questions, and that is non-pharmacologic considerations. Now, you need to know that EMFs, electromagnetic fields, are like the worst thing in the world for your testosterone levels. When I see people have their cell phones in their pocket, either in the front pocket or the back pocket, it's a recipe for disaster. Or women that put it in their bra. And I see this people just tend to do that. Don't put your cell phone in your pocket if you care about your hormonal levels and your overall health in general. And there have been studies that have clearly shown that. It's a known fact. What about certain foods with a negative impact? Yeah, soy, for example. Now, soy was a real health food a few years ago, and it's still touted as something healthy for prostate health. But it isn't healthy for your sexual function and your testosterone level. So I avoid giving soy or recommending soy for my male patients. Other things like vegetable oil. Well, who uses vegetable oil anymore? That's basically processed oils like soybean oil or corn oil, or there are processed oils that can turn rancid, and also they're pro-oxidants. So pro-inflammatory, so I don't recommend them anytime, but certainly not if I want to maintain good testosterone levels. So I stick to things like olive oil, coconut oil, and avocado oil. This is a new one that I didn't really know about. Nuts. Nuts can have a negative impact on testosterone levels, and because actually certain nuts can increase something called sex hormone binding protein, SHBG, and that actually can bind the testosterone and make it less available for binding sites. However, Brazilian nuts are high in selenium, and that's been shown to actually be useful in increasing your testosterone level. The other thing is I want to talk about is sleep. Sleep is so important. They've done studies. They actually did a study in 2011. They took several men, and they made them have sleep deprivation for like 5 days, and they dropped their testosterone levels like 15%. So sleep is really big these days for a myriad of reasons, but if you want to maintain your testosterone levels, getting adequate sleep is really important. And the one thing I also want to mention that I recently learned about is a compound called acetyl L-carnitine, ALC. Now, those of you that know me know that I'm very big on L-carnitine. L-carnitine in itself is very important for energy production, and all the cells in the body need it. And you're talking about the brain and the heart, they work 24/7. So what L-carnitine does, it transfers fatty acids in the interior or cytoplasm of the cell to the mitochondria. It shuttles them to the mitochondria, which is really important because the mitochondria is the powerhouse of every cell, whether it's a heart cell, a brain cell, a colon cell. All those cells need energy to keep going, and it's through the L-carnitine. So it's actually a shuttler of fatty acids to where they need to go to produce energy. So you can have all the CoQ10, all the ATP, but you have to have enough L-carnitine. So acetyl L-carnitine is the only real carnitine that crosses the blood-brain barrier. And it's been shown to not only increase testosterone levels, but it can actually improve cognitive function, energy. And I don't think it's just restricted to men. I think women can use it as well. But there's actually studies that were done by Italian group, Dr. Cavallini, in like 2011. So it's not a new thing, but most people don't know that acetyl L-carnitine can have a positive effect on testosterone production and sexual function in general. So, and it is relatively inexpensive. So that's what I have to say. Now I want to hear your questions. So let me put my glasses on and see what people are in the chat box. And good. All right. What are the best supplements to raise testosterone? Okay, those are called testosterone boosters. I'm gonna be honest with you. I've tried them. I've used them on patients. I do not think any of them are that great. You've heard about Tribulus, Trestus, whatever is one that's been used. And other than acetyl L-carnitine, I don't know if I would try those boosters because they could also actually increase your estrogen level, which we don't want, and have other adverse effects without really having a major impact on raising your testosterone. So I have not been impressed with testosterone boosters. I think if you really need to increase testosterone, the best way to do it is just take the hormone. Same thing with estrogen. I mean, with certain foods can help, but and I've never seen a supplement that I'm sold on yet. So we'll see. Okay. What do you recommend for reducing PSA naturally? Okay, interesting. Okay. So PSA naturally, first of all, I never get upset when I see a PSA level unless it's off the wall, like 12, 11, So oftentimes when I see a PSA level that's elevated on a patient that's on hormones or not, what I'll do is do nothing at first and have them repeat the test in about 5 or 6 weeks. Oftentimes it's come down, the numbers have decreased. And if it hasn't, then I will probably stop the testosterone, have them be seen by a urologist, et cetera, et cetera. Now, how to prevent the rise? Again, it's the red stuff, okay? It's the lycopene. It's really been the most useful of all the foods. And also things like legumes have been shown to be useful. Fish oil, and of course, lifestyle. So, when you have an elevated PSA, I watch it. I'm not a urologist, but I'm quick to refer them to urologists if I see that the numbers are increasing instead of decreasing. But lots of times, even if it's, let's say it is prostate cancer, okay, and I'll sit and watch it because lots of times it is about watchful waiting, unless have someone young, like under the age of 60, that has a rising PSA. But oftentimes these men have prostatitis and not prostate cancer. So keep in mind that PSA is not specific at all for prostate cancer. And prostatitis is pretty common. And prostate symptoms are also common. As far as other things I can use, I'll use like saw palmetto, stinging nettles. Those are supplements that can be useful for prostate health. So there's lots of things you can do. Okay, thank you. Where do you go for... Let's see. Supplements. Okay. Coffee enema for cleaning your colon. A lot of people in I don't want to say just not the functional medicine, in the alternative world. Okay. Because even people in functional medicine, we don't tend to just gravitate to coffee enemas. Or some people in the alternative world are using coffee enemas to cleanse the colon because we know the gut is important in overall health and immune health. But when I do that, routinely, I don't recommend. I'm not into I don't do. I don't do colon cleansing, and I don't do coffee enemas. But it has been used. There's some very well-known alternative physicians who have used that in their approaches to cancer. We're talking advanced cancer, like stage 4 cancer. And but you got to do it every day, and it tends to be pretty messy. So I personally have never found a need for it in my practice, and I'm pretty open, as a lot of you know. But but I'm not against it. I don't think it does any harm. But I worry about. I always concern myself with people doing these colon cleanses and so forth, because that can really affect the flora. And as it is, we're living in a time in which, between the environment and the food that we eat and the stress that we have, that our flora is already messed up, and we really need to. We don't want to upset and get into more dysbiosis or leaky gut by doing things unnaturally to our colon. So I'm not a big fan. Let's see. How do we manage this whole thick blood thing? Okay, this is a question that I've been asked, and I see in my practice. One of the ways testosterone works is by increasing bone marrow production of red blood cells, the release of red blood cells into the circulation, which is actually a good thing, right? Because with more red blood cells, you have increased oxygen carrying capacity, more muscular endurance. So it's actually a good thing. However, in certain men, it goes overboard. The process is overboard, and we have to deal with that. When I start seeing a hemoglobin of 18 or higher, or hematocrit of greater than 50, I get concerned, and then I'm going to have the patient. There's a couple ways of handling it. The best way of handling it is just to do bloodletting, or do what's called a therapeutic phlebotomy. You go to a hospital or the Red Cross, they put a needle on your arm, they drop it back on the floor, and the blood just comes out in 5 minutes. That's one way of doing it. There have been other ways, like you take a week off every now and then. Let's say you're doing the gels, which is a daily ritual. Maybe once every 6 weeks, you go a week without it. And I've heard a new thing recently that if you do injections, maybe instead of doing one injection a week, which is what I generally recommend, split it into 2 injections a week. These are all solutions that I have heard about. There's no science behind it, at least that I have found. So there's several things that we can try, but if we have to get rid of the blood, we do a therapeutic phlebotomy. And why do we even need to get rid of it? Because too much red blood cells can cause sludging. And the last thing we want is an increased heart attack or stroke. And it's been very rarely reported. It's been over-exaggerated in the literature. But yes, I do insist, if the blood gets too thick, the hemoglobin hematocrit get too high, that patients undergo a phlebotomy. But I will tell you, in 22 years of administering hormonal therapy, I've never seen a case yet. But, I do follow the guidelines. Okay, don't you need a commensurate amount of white blood cells? Yeah, you have 3 major blood lines. You got white blood cells, red blood cells, and platelets. I don't know if I understand the question, but testosterone should not affect your white blood cells or your platelets. But it can, like I said, what it will do is increase red blood cell production in the bone marrow and release. So that's the major issue there. What else? Let me see. Oh, here's a good one. What if children are in my future? What do I do? Now, if you want to have a good source of birth control, go on testosterone. Because once you're on it, you're going to tell your testicles, you're like, oh, no need to produce anymore. I'm just going to go to sleep. And actually, this could be a potential problem, because some people are young and they have low testosterone levels, and I am using testosterone. So what we do, we stop. Well, first of all, you can freeze your sperm if you want to do that and use it for future usage, or you can do a combination of HCG and Clomid. I do that all the time. I've done it successfully for many years. So HCG is human chorionic gonadotropin, which is an analog of another hormone in the pituitary gland called luteinizing hormone, or LH. So that tricks the testes into thinking that, I'm going to put out some testosterone. So it works your testes to put out more testosterone. Then we chase it down with Clomid, which works in the hypothalamus and pituitary. So you have the HPT, I'm getting a little technical here, hypothalamic pituitary testicular axis. And that's really how your body makes testosterone. So we're just using HCG and Clomid together to get back to your normal levels. And I've had many men that we were successfully able to reproduce sperm, because what happens is testosterone will affect not just your sperm count, but your sperm motility. And those are both very important. And so by using the HCG and Clomid together, and sometimes I'll I'll do a sperm analysis in between, but oftentimes they've been on hormones for a while. I will probably do back to back HCG and Clomid. But there's one other aspect of that HCG that we use, and that is for the men that are on testosterone replacement therapy, because you will more than likely experience some degree of ball shrinkage or scrotal atrophy or testicular atrophy. And so by giving you HCG I do it every 3 months, it actually wakes up your testes, and it'll make it it'll augment testosterone production, which has been sleeping while you're giving weekly injections or daily topical administration. I've been very successful with that. There are some protocols that add every day, every week. I have found no usage for that. Then the science behind it is not that great. But what works for me is doing HCG in 4 different injections over a period of 12 days every 3 months, which work really well. Oh yeah. Okay. So my urologist tells me to get off testosterone. They're going to do that. And a lot of endocrinologists won't recommend it as well. So this is when you have to become your own medical advocate and say, what are the risks versus benefits? If the benefit risk ratio is in your favor, then you as a medical advocate has to make your own decision. But you may get slack from urologists. You may get slack from endocrinologists. Why are you taking testosterone? Why do you need it? And it's a personal decision. I don't recommend everybody, even though I am pro-hormone and anti-aging. I think it's an individual decision. So you have to make that on your own. And yes, if you have a PSA that's rising, and if you have prostate cancer that's active, then I can definitely see agreeing with your urologist. But you may hear this. I have a few patients that see their urologist, and they say, why are you still taking this stuff? And they get into a little thing with them. But anyway, those are issues you may come in contact with. How long can I take it? Forever. I don't plan on stopping because of the way I feel and what it's done for me in the years that I've been on it. So there's no time frame. Just like what I said with women, you don't just take it for a few years. You take it as long as you want to be physically and mentally active. So I don't stop. So I want to make sure we get the thing about prostate cancer and heart disease. That's really important. So many of you have heard, and some doctors, that the old time doctors still think that testosterone leads to prostate cancer. So where did this come from? This came from 1942, okay, 79 years ago. This Dr. Hudgens, who eventually won a Nobel Prize for his discovery that taking men with advanced prostate cancer and castrating them actually could be useful. And he received the prize for this in 1962, many years later. Now, first of all, the way we looked at prostate cancer back then was very different. They didn't have a PSA. We looked at levels called acid phosphatase. No one even looks at that level anymore. And we found in subsequent studies by a brilliant urologist in Harvard, Dr. Morkentellier, I can't pronounce his name right. I'm sorry. I can get you the name though. This guy did extensive work during his fellowship and beyond, that there is no link between prostate cancer and the usage of testosterone. Now, if you have active prostate cancer, since it's a hormonally driven cancer, it could lead to an increase, but even that's controversial. But as far as a link between the hormone and prostate cancer, it's just not there. It's been discounted. Now, heart disease. When I was really writing about heart disease, and I wrote a blog on this in 2014, I've done a video on it. It's all on my YouTube channel and on my website. There was 2 studies that came out in late 2013 saying, oh, testosterone is linked to heart disease. This is nothing new. They've tried this before. The studies were deeply flawed. They didn't measure estrogen levels, which is very important. They didn't measure hematocrit and hemoglobin levels. They didn't even measure, in some of these cases, testosterone levels. So we didn't even know what the levels were. So again, it was a deeply flawed study, and my job was to say it is flawed, and you got to look at the science behind it and how the studies were designed. So again, as a cardiologist, the last thing I would ever do is to give someone something that would damage their heart. And if anything, testosterone can be a booster. There are receptors in the heart there are receptors in the brain for testosterone, just like there are for estrogen. And actually, it can affect nitric oxide levels and improve vasodilatation and increase blood flow to the heart and to the brain. So they've done also numerous studies. If you go to my blog that I wrote a few years ago on my website or my video, you'll see a list of references. And I reference various studies that show the ill effects of low testosterone on the heart and the positive effects of testosterone in patients with heart disease. Okay, well, let's see. We're almost finished. Let me see. Any questions here? Okay, here's another question. What do I do if my estrogen level rises? And that's going to happen in lots of cases. Now, what happens is that when we give you testosterone, if I showed you the chemical structure of testosterone and showed the chemical structure of estrogen, you couldn't tell the difference. I couldn't tell the difference because they look so similar. But of course, they're obviously different hormones. So your body gets tricked, and your body will look at some of the testosterone and will convert some of it into estrogen, which you don't want. It doesn't happen to every man. Like, it doesn't really happen to me, but it happens in probably about 40 or 50% of men, in which their estrogen levels will rise along with the testosterone levels, which you don't want, because estrogen is, although it's very protective in women, it's not in men. In men, it can cause premature heart attack and stroke, not good. It can lead to prostate enlargement, not good. And a host of other problems, water retention and fat gain in men. These things we don't want, right? So how do we deal with it? Well, we deal with it by giving estrogen blockers, and you can become pretty good at this after a while. I don't do it routinely. I wait and see. That's why I see patients in 2 months, because in 2 months I can see what direction we're going. And usually men that have a lot of fat, increased fat cells, the aromatase enzyme that converts testosterone to estrogen is in fat cells. So I can kind of gauge it. And I look at their baseline levels. If their baselines are a little high already, then I'm going to start right away. But I generally wait until I've done the second blood test, which is 2 months after starting. So we can manage high estrogen. We can manage high hematocrit and hemoglobin. And that's why you want to go to a doctor that does this all the time. And then I think these fears about prostate cancer and strokes and heart attacks, it's really minimized. Okay, I think I don't see any other questions. Let me just my last one real quick. Okay, I think we answered all the questions. So again, for those of you that are men, I wish you best of luck in Men's Health Month. And I'm so happy that we have this month, and we'll go over there. I will see you in 2 weeks for our next YouTube Live. So thank you very much for participating, and we'll see you in 2 weeks. Good night now.